Hi, everybody. Thank you for coming out. I'm Sharon Anderson, president of Leiomyosarcoma Support and Direct Research Foundation, or LMSDR. And I am going to hand it over to my good buddy, Susie Siegel, who's going to tell you all about our guest speaker today. And she's muted. There she is.
I'm delighted to have Dr. Matthew Spraker with us today. He's an MD, PhD, and a radiation oncology at CommonSpirit Health in Denver. He talks about radiation therapy on the Accelerators podcast, and he has been very involved with the care of sarcoma patients.
Thank you.
Welcome, Dr. Spraker.
No, I really appreciate it, and I really appreciate the invite. So thank you very much for having me. I'm going to share my slides here. Oh, there we go. Okay. Can you all see this?
Yep, loud and clear. Yep.
You're still seeing the slides, I'm assuming. Yeah.
Yes.
Okay. I never know how this works. So, okay, I'm going to make it a slideshow so we can look at it big. And I just wanted to tell people, oh, you're probably seeing the presenter view, right? How's that?
No, we're seeing the slide and the presenter both.
Is it now just the slides?
No, you're still in there, a little tiny box, but we like that.
Do you see the slides though, right?
Yes. Yes.
Okay, good. Okay, so you know, I took a little bit of a different approach here. I know that we wanted to do decision making in leiomyosarcoma from a radiation oncology standpoint, and so what I tried to do was actually develop some cases to run with you all as if we were teaching residents or trainees, because I think the things to talk about here are really important. And so I'm going to move quickly, and I tried as hard as I can to keep things you know, really straightforward without getting too much in the weeds, but please ask questions here at the end, or you'll see I give my information at the end. Please reach out to ask more questions, things like that, if I blow past something that you're curious about. I wanted to start out just by answering the question, what is a radiation oncologist? Because actually my own family doesn't always get this one right, even though they've been with me through this for all this training and everything. And I wanted to just clarify it for you. And I want to start by going way back to the very beginning, 1895. This is Wilhelm Röntgen. This is the father of radiotherapy in medicine, or radiation in medicine in general. And if you go back and look at this guy is a scientist at the time. He discovered these strange rays that he eventually at one point must have thought could be see into the human body. And he did what I personally would not have done, which was grab his wife out of the house next door and say, hey, stick your hand in this machine. I'm going to take a picture of it. And she did that for him. And she explained, I have seen my death. That's like the famous story about how X-rays were discovered in medicine. And I don't know if she actually ever said that. She probably maybe saw his death, which is probably the way it would go for me if I tried to X-ray my wife with some strange rays. But either way, she did not die from X-rays. There was no toxicity from this. It's really well reported. And Anna Ludwig was his wife, and she doesn't get talked about that much except for the subject of this very famous picture. So I wanted to just shout out that they met at a coffee shop, and she supported Wilhelm throughout his entire career, like many of our partners do when we're in medicine, was a genuine supporter of her family. So thank you very much to Anna Ludwig for giving us radiation in medicine. And so to clarify, what is a radiation oncologist versus a radiologist or an interventional radiologist? And all of these people are very important to sarcoma care. So you will see all of them. We're actually not brothers. They could be sisters too. And we have the same mother. It was kind of a weird title, but it seemed cool at the time. So I put it up there. But basically, radiation oncologist is a very specific field. That's what I do. These are doctors that use radiation to treat disease. That's primarily what our role is. We treat mostly cancer. There's other non-cancer diseases we can treat with radiation occasionally, but it's mostly cancer. And what makes us unique is we have clinical oncology training. So everyone says my oncologist, like the medical oncologist, but we actually have dedicated oncology training as well. Just like a surgical orthopedic oncologist, for example, that operates on sarcoma, they have special oncology training. We do that too. And so we're part of this historical triad that I envision of how we treat cancer in general at a very high level, which is surgery, chemotherapy, and radiation. We're the radiation part of that. Now, Not always true. What's changing is that we have radiologists and interventional radiologists that are two other types of doctors. They actually come from the same field, but they now are separate. So it's a separate field from radiation oncology. They have separate training. They are imaging-based and procedural-based training. In other words, if I have a question about an image that's very nuanced, I'm going to call up my radiologist who's going to tell me all about that. And these days, you may actually hear about treatment from these doctors as well. Radiologists do ablative procedures. Interventional radiologists do the same. They often perform biopsies in the sarcoma world, so you will meet them from time to time. And then actually, they even give radiation now. There's a special type of treatment we won't talk about today, but that's usually delivered by an interventional radiologist called Y90, and that is a radiotherapy treatment. It's just not one that we deliver. So lines are totally blurred, but I wanted to just clarify here that we are different types of doctors with different training, but all came from Wilhelm's finding back in 1895, and that's where we are today. So now that you know that I'm a radiation doctor that gives radiation treatment, how do you actually get that? So the way you get it is actually many different ones, but the one that you're going to hear about most from most doctors in most settings is what's called external beam radiation therapy or radiotherapy. And this is where you lay on a table that is near a giant machine that looks like this. And then this machine makes beams of radiation therapy. And our job as the radiation doctors is to design those beams in a logical way to cure your cancer or make your symptoms better or help with the cancer in some way using our radiotherapy. When you hear about proton therapy, that's another form of external beam radiation therapy. This is in contrast, for example, to something called brachytherapy, which you may hear about in the sarcoma world as well, is a different type of radiation therapy, also delivered by a radiation oncologist, but it's just totally different than for what I'm going to talk about today. Now, I can't do the whole field in a single half-hour talk, and so I'm going to focus on external beam because that's primarily what we use to treat most patients. And in fact, this machine you're looking at right here, this is not mine personally, but we have the same machine in my clinic. And so this is literally what my patients see when they walk in the room to get treatment with me as a radiation oncologist for sarcoma or otherwise. And so what does radiotherapy do for people? It cures and it comforts. And I like to drive this home because it is not just a curative therapy, but it is a very important one. And it is not just a comforting therapy, but it is one that makes many patients with sarcoma feel better. And because this is a leiomyosarcoma foundation, I want to talk about what it does specifically in this disease. And there are three things that I think are really important for you to know. It's not an exhaustive list, but these are three things that I would say are my favorite things or the most important things that we do as a radiation oncologist for patients with sarcoma. And so this is in the curative setting when you have a localized sarcoma of the extremity, including leiomyosarcoma. We allow surgeons to do a more limited surgery instead of an amputation, which I'll talk about. In the metastatic setting, when patients has disease that's spread away from their primary tumor, a lot of times in sarcoma, as you may know, that goes to the lungs. We can ablate those tumors together with some of our other colleagues. It's kind of like a surgery with the magic rays of radiation. Talk about that too. The last thing I'll talk about today is that it's a really, really good tool to help with symptoms. And I think sometimes that's not as well known, and one of the most important things I want to have you walk away with today. And so just like the trainees in my clinic that I used to work with, I'm going to have you guys run cases with me today. And so let's start with our first case. This is going to be a leiomyosarcoma of the extremity. That means like the arm or the leg. Okay, so you guys probably know this is a set type of disease that we deal with a lot. It's common. Leiomyosarcoma is one of the most common types of sarcoma, and we see it in the arms and legs not infrequently. And so this case is a man that presents with a lump to your clinic. 68-year-old guy. He's got this lump on his elbow for 3 months. This is a little outside of the scope of this talk, but you can, if that's happening and this isn't going away, you probably got to look at it a little closer. And someone who's 68, you can't just ignore it. And so that's exactly what happened. I'm putting the medical terms for you all in the parentheses here, but I like the regular English ones too. So what is it exactly? He gets a biopsy, and what we're dealing with, I bet you're not surprised to hear this is a leiomyosarcoma. If you're, you may know that there are different types. This one happens to be a pleomorphic leiomyosarcoma, and it is high grade. That's the important what is it question. So this is a cancer and not something else. It is a sarcoma we have to deal with. And then the next question I always ask, and you may have heard this in your other talks, is we got to stage the patient. So we now know what it is, but where is it in the body? And that defines how we treat it. And so for this patient, we have to measure it. It's a 5.5 centimeter mass. It's a couple of inches. Heterogeneous just means it looks like it has all different kinds of textures on the scan. And importantly for us and for our surgeon colleagues, it's not in the muscle, but it's above it. And so it's kind of under the skin, between the skin and the muscle, and it's not involving the bone. These are important things that are probably outside the scope of this talk today, but they're important for surgeons and radiation doctors to talk about. So I wanted to put that in there for you all. And then, of course, as you may be aware, we also image the rest of the body to find out if it's spread anywhere, and that gives you your stage, right? And so for this patient, the technical stage, you don't have to remember this, is just a T2N0M0, which is a stage 3A in sarcoma because of the grade. Don't worry too much about that, but I wanted to give you this because it sets the idea of how we need to treat it. And so what I do as a doctor, once I have the stage, is I get together with my multidisciplinary team. This is a surgeon, medical oncologist, radiologists, pathologists, other doctors. We get all together and we talk about what the best treatment is. And I wanted to put this up there because I like to pretend that we all have this in our heads memorized, but actually really smart doctors all get together and make these recommendations for the country. So in the US, this is how we treat people for stage 3 disease. And again, you don't have to remember this. The key here is that stage 3 disease gets a limited surgery. What I mean by that is not amputation. So they just take the tumor out, not take off the whole limb. And then we add potentially radiation or chemotherapy. And so this is the strategy for these people. This is the medical way of saying that. I broke it down for you to say that it's important to find out if they can have surgery, and then we either add radiation or chemo. And I want you to understand how we got here, to understand the value of radiation. And I'm going to set aside the chemo piece. You probably heard about that from Dr. Ganju, and it's controversial, and my job's a little bit easier, so I'll talk about the radiation part. And so the way we got to this recommendation, surgery with radiation therapy for certain patients, is through 2 randomized trials that happened in the 90s. This is before my time as a physician, but I know these people, these individuals were all giants in the sarcoma world. And what they did in the early 90s is realize that maybe we don't have to do amputations for patients. So if this patient showed up with a tumor in their elbow, we would do an amputation around the elbow to get rid of the tumor, and that could cure a lot of these patients. But you can understand how if there's an option to not do an amputation, that's very attractive to patients. And so these doctors wanted to find a way to do that. They didn't come up with this on their own. There was a trend in the 80s and 90s of making surgery smaller and using radiation to clean up any tumor cells that might be left behind and allow for a smaller surgery. And they showed just that. And so they tested, and just like in our man here, they tested where half the patients got surgery, half the patients got a more limited surgery and radiation, and they found that the outcomes were the same. And so whenever we see that, we now say, great, we don't have to do amputations anymore for most people, and therefore we can now set a new standard of care where we can do a smaller surgery and use radiation to help us out. Then they asked the number one question, okay, we can do this smaller surgery. Does everyone really need radiation? And they tested the question that way. And they said, let's take everyone with our man with an elbow mass. Everyone now gets a limited surgery. Let's give half of them radiation and half of them not. And let's see what happens. And we found that radiation offers much better outcomes. Again, not we, I wasn't there for this, but my colleagues found this. And we now know that for certain patients, basically patients with high grade and larger tumors, if you're going to do a limb sparing surgery, if you're going to not amputate the patient, you need to do radiation to prevent it from coming back. And that was great. But the catch here is that in 1990s, we found that if we asked the patients how they felt, the side effects of radiation and the quality of life of the patients after they had radiation compared to ones who didn't was actually a lot worse. And so you get this beautiful new thing where we can avoid an amputation, but we've left patients now with range of motion issues, stiffness of their limb, swelling. This is like the guy can't move his elbow as well as he wants 6 months after treatment. So that's a problem. This is back in the 90s, though. I get the joy of doing this in 2024. And what has happened since then is we've made huge gains. And again, not me personally, but the medical physicists, the therapists, all the technologists and engineers in our field, to go from where this is my very medical stylistic bone. This is a bone, and there's the tumor next to it. And you can see how back then in the 1990s, we give these giant fields where we radiate the whole bone and the whole arm. And then these days, we just radiate a very small field around where the tumor was. And it's hard to understate how impactful this has been for patients. We went from a place where people had the same quality of life with a radiated elbow versus an elbow that you literally cut off, right? I like to bluntly put that so people understand how toxic this used to be. Nowadays, it is the standard of care where most people do not get amputations and they have excellent control and very good quality of life in the long term. So we've made huge gains, and we've done that through better personalization and much better understanding of the biology of radiation. And so the way we do this, let me show you some technologies that we've developed that came a little before my time, but they're now standard of care. One of these very important ones, maybe the most, is intensity modulated radiation therapy, or IMRT. And what this means is that we use special devices to take our beams of radiation and we control the high doses. And so what this looks like in practice, here's that machine I showed you. This is that like arm. This is where the dose comes out. Right here, same arm thing right here. This is where the beam comes out. And what's inside that arm these days are all these little metal teeth. This is like looking down the barrel of the gun. And you can kind of see that all these little fingers are things that can move in and out like this and block and shape dose. And here's a nice example of that from prostate world, where we use these differently shaped beams to give highly shaped and personalized dose shapes to these patients. And why does that matter? Let me show you the schematic. I actually took this out of a medical physics book, so I'm going to teach some patients medical physics to brag about that. But basically, this is a blob that's supposed to be a patient, and these numbers represent the relative dose to what I've prescribed. So if you put one beam in from the top like this straight down, so I'm looking right here, you put it in, where you put it in, the dose is higher at 70%, and then it gets to the place you want it to be at 60%, and then it falls off as you go through the patient. As you add another beam, you can see how it evens it out more. And then as you add another set of beams, now you have 4, you've noticed that all of your dose inside the red has stayed the same. This is your target. And we've now traded high dose outside the target for more lower dose, but the lower dose doesn't matter as much. And so the idea here is I don't want to get too bogged down in the details, but basically if you can spread out the low doses all around the patient, they don't really feel that. And so you sort of get that for free, so to speak. I'll talk about that in a second. And then you can still keep your high dose in the area of the tumor that you want it, and you make the toxicity much better this way. And here's what it looks like in practice. This is a fun figure that comes up all the time. And what it's showing you is basically high dose region. There's no number on that yet, and that varies from patient to patient and how we give it. But this is what I would consider like dose that could cause toxicity or side effects. In the 2D era, in the 80s and 90s, when these ideas were generated, this is what it looked like. And this is a head and neck patient. So here's their mouth, the back of their head, and here's their face. And this is an example of a head and neck cancer where you're showing that if you give just those 2 beams across, you can see how the whole face gets dosed. If you add more beams now and you shape it better, you can see how we're sparing parts that are important. IMRT is the modern era, where now you can see how the high dose is so much smaller than it used to be. And more importantly, we can intelligently shape it around things that matter. In this case, we have the salivary glands. For example, when a patient has head and neck cancer, we care a lot about dose to that. And so we can use this technology to shape that dose. And so IMRT is a standard of care now for the extremity. And I want to bring you back to my patient to put this in context for you. So we have a recommendation for this patient. I'm going to recommend radiation. Remember, going back, they have this tumor of the elbow. We don't want to do an amputation. It's too large and high grade to do surgery by itself. So as a standard, we add radiation. I'm going to add it before surgery here. There's a discussion to be had about that, but we're going to add it before surgery. And the benefit for the patient is to improve the chance of local control. And as long as the tumor hasn't spread, that means we're also improving the chance of cure. Now, I'm choosing preoperative because I can make the field as small as possible that way. And sometimes it's not, sometimes you want to put it after surgery, and I don't want to get too bogged down in that. That's an important conversation I would say every patient needs to have with their radiation oncologist, but it has to do with the trade-off between higher risk of side effects in the long term from the radiation if you do it after, versus if you do it before. You can give a little less radiation to a smaller target, so less in the way of long-term side effects, but you might make it a little harder to heal the wound from surgery. And again, I don't think it's worthwhile to get bogged down in this because it's so personalized at this point that you really got to talk with the surgeon and the radiation doctor, you know, at the time of your care to really understand what's best for you. And what I would say is that the best thing you could do is if you have a doctor where you've been diagnosed and you're going to head to surgery and there hasn't been a discussion of radiation, you could ask that it's talked about before the surgery. A lot of times it is important to give it after and not before, but you always want to have the conversation up front. And then these days, I tell all of my friends and colleagues and families and patients that IMRT is standard of care. This is new in the last couple of years. If you are getting radiation for sarcoma of your arm or leg, it is a leiomyosarcoma, you should be getting IMRT. If you're not, there should be a good reason for that. And so I want to make sure that everyone knows that it's standard. The last way that I like to tell patients is how do we give it or how much do we give? You might be aware that the standard of care for, God, it's got to be 15, 20, 25 years now, is to give 5 weeks of radiation Monday through Friday. It's daily treatments where you come from home. So you come from home, come to our clinic, get on that table, get your treatment, get off the table, and then go home. And then you do it again Monday through Friday for 5 weeks. That's the old way. I tell patients it's tried and true. We have trial evidence of hundreds of patients getting treated this way, and it works really well, and I know what I'm getting every time. What's hot and new, I like my little rhyming there. What's hot and new is we can do it shorter, right? This is a trend you're going to see in radiation oncology across diseases, is that we can actually do it shorter safely. You can take this 25 treatment and use IMRT and all the technologies I'm going to talk about in a few minutes to compress that treatment down into 5 treatments. You'll learn and see that the dosing isn't sort of 1-to-1. It's not like we give 1/5 the dose. This is where the biology comes in. But basically, we can give a 30 gray or 30 units of radiation in only 5 treatments, and we get the same outcomes. That's been tested now at like 3 or 4 universities, and we're seeing the same outcomes between the two. And so when I talk to my patients about 50 and 25 versus 30 and 5, I say, look, I'm cool to give you either. You have to know that 50 and 25 has decades of experience and we love it. 30 and 5 has great experience and I love it too, but it's pretty new. It's only been published in the last few years. I have a pretty high number of patients that prefer the 5 weeks because it's tried and true, but I also get these young patients or people that are working or live far away or busy, and it's very convenient for them to do 5 treatments. So to conclude out this case, this patient was just that. They chose 5 treatments because they're very busy. So we did that. During treatment, generally, I tell patients that they can expect some mild fatigue or moderate fatigue or even more, and that comes with any kind of cancer treatment. In general, the days of these skin burns from radiation are kind of no more, and we don't see that very often, although we do sometimes. And so as expected, this patient's skin got slightly pink. There was no pain from radiation. They didn't become radioactive. Unfortunately, no superpowers or glowing or anything cool like that, but generally very well tolerated. And then a lot of times when we treat these, we feel these masses get a bit softer. To me, it just probably represents death of the tumor on the inside, and they get a little bit softer. When you do these short courses, a quick caveat is they go to surgery pretty quickly, whereas if you do the longer course, they don't. So this patient finished the radiation. They went to surgery 9 days after they finished the radiation. They didn't have any wound complications, which is typical for the arm. It's very uncommon to have wound problems in the arm, even with radiation. They did what I always want, which is they initiated physical therapy after. It's a very mobile area. You want it nice and strong and flexible in the long run. And then they're doing very well now. And then, as you all may be aware, whenever we finish someone's curative treatment, in this case, chemo was not recommended for this patient. Therefore, they go on to get CT scans every 3 months for the first couple of years. And then we MRI the elbow every once in a while to get a good picture of it. That's our first case. So clear as mud. I'm sure you all could just treat it now. I want to show you the fun pictures. We do a lot of stuff on imaging and radiation. So this is a planning scan for this patient with the elbow mass. Just to orient you, this is looking at the person head on. The 2 lungs are right here. We're kind of towards their back. Here's the spine, shoulder blades. Here are the 2 arms coming down, 2 legs down here. Here's the elbow with that tumor, elbow joint right here. And here's the tumor. I've actually outlined it in red because the first thing I do when I get a planning scan for radiation is I tell the computer this is where the tumor is. An MRI is used for this, by the way. I can't show you that at the same time, but it might look a little different throughout because the MRI sometimes makes it look a little different than the CT. Now, what I'm doing here is I'm taking a line through this, cutting it right here, and I'm showing you a cross section. Okay, so here's the bone of the upper arm. Here's the muscles of the upper arm, the fat underneath the skin. Here's that tumor right here. You can see I've outlined it in red to tell the computer that's what it is. And then what I do is I tell the computer, okay, well, here's the tumor. This pink now is actually the part where I know that there's tumor cells that could be trying to hide or leave this tumor and creep along the fat and form a recurrence maybe over here. And so I got to capture those tumor cells. And this is a geometric expansion. I do this based off of the hard work that my colleagues did before me in running clinical trials. Remember I said those targets got way smaller? That's this. So this target is way smaller than it used to be back in the day. And so what I do is I put this pink on to say, let's capture any microscopic disease that might be trying to sneak out. And that's called a clinical target volume. Then the last thing is this orange. And this is me telling the computer, look, I've covered this tumor. I've now covered the microscopic parts of it. But what about if the patient is over to the left or the right a little bit each day? We got to set up a little wiggle room margin. My physicist is probably pulling his hair out. It's called a planning target margin. It's for setup uncertainty is the medical term. It just means if you come in each day and you're a millimeter to the left or the right, this is such a tight plan and these are so precise now that millimeters matter and we have to build in that wiggle room to make sure that we don't miss the target from day to day. Elbows just move a lot, so you gotta like make sure you know where they're at. Then what I do is I tell my planning team, this is where I take all the glory and they do all the work. They work very hard on the computer to develop a radiation plan. And let me show you what this is on the computer. So remember that big treatment head that I was showing those little fingers? This is showing the path of those beams. And so what it's doing here is the machine will rotate around the patient in this angle. And every single one of these little ticks is a brand new beam. And so in 2024, I now have a souped up version of IMRT called VMAT. And what I can do with this is I can give many, many, many beams. In this case, it was 180 beams to this patient that are all individualized to try to cover this tumor well. And what do I get back? This looks pretty simple and easy, but it's actually pretty sophisticated. What this is showing me is with high accuracy what the doses are going to be on the patient if I deliver the plan the way I expect. And so what I'm seeing is my prescription dose in the red is covering the tumor. I want to just point out here, I intentionally don't cover it at the skin because it's coming out anyway, and I don't need to make people's skin very have a lot of side effects. And so this is typical for this. We can see that you can't make the dose go from the full dose to 0 over no space. So you can see how the lower dose, like the 20 gray, is about 60% of what I prescribed, has spilled outside of my target. But that's just because it has to. And then the even lower doses is that 10 gray. But what's really important here is you can see that the red, the part that causes side effects and kills tumor, I only have that where I need it, and I'm purposely trying to have it cut across the bone. I've learned in sarcoma world that if you don't treat the whole bone, that the risk of fracturing it in the long term, for example, is way lower. And so these are things that radiation oncologists do to shape the dose to minimize the risk of side effects for the patients. And the best evidence that we've done a good job of that is just the clinical trials across decades. If you compare that first trial to where we are today, the way that patients live after this therapy is so much better than it was in 1995 or 1998, whatever year it was. Case number 2, moving on. I'm behind here, so I'm going to go quickly. We have a single lung metastasis for retroperitoneal leiomyosarcoma. Let me skip the case because I'm going long, and I want to tell you about SBRT. This is a patient who had a cured cancer that has now had a recurrence a year later, but she's pretty frail, and because of that, we can't give chemo. And so because there's just one spot, what do we want to do about it? A frequent recommendation is SBRT. What is that exactly? What that is I use all the technologies that I've talked about, and I basically can turn the dose, or I crank it to 11. A surgeon said that to me once, and I'll never let it go. Basically, you deliver a very high dose of personalized radiation therapy in a single treatment or a few treatments, and then you deliver that, and it sort of changes everything. But one of the problems is that if you deliver these very high doses and you plan it on a computer, how do you know that you're not missing? I'm going to skip over this, and I can come back to it if we want to talk about it, but we do that by incorporating imaging onto the treatment machine. So I just explained how we can shape the dose very nicely, and you probably had in your head, that's great, you can shape it to be so precise, but what if you put it in the wrong place in the patient's body? That's not very useful. And so we got to make sure we hit our target, and we do that with imaging. And so let me just skip over this and kind of show you what I mean by that. And so sorry, let me just show you what I mean by that. I'm missing right here. And what I mean is that we can do those plans that we just what we talked about, and then we put the patient on the table to deliver it. And then we now have some treatment and imaging modalities built in. So my machine, for example, has a CT scanner on it. So the patient gets on the table for treatment. I can run a quick, what I call a poor man's CT scan. It's not as good as a diagnostic one, but it tells me the information I need. Is that elbow in the right place? Is that lung metastasis in the right place before I deliver that therapy? We actually have machines now that even have MRIs and PET CT scans. There's all kinds of stuff you can build in, and we can do lots of cool things where we can take IMRT, add it to our images, crank the dose way up, and that's what you get with SBRT. Now, what does it mean specifically? There's no specific dose. There's not even a real definition, frankly, about what SBRT actually is. There's no formal definition, but what it is a very high dose per treatment, and it gives us a new biology where we can kill resistant tumors in place. And so again, what I mean by that is, remember before we were giving radiation to kind of sterilize an area where they're going to get a surgery. That's a lower dose. We're going to give a much higher dose to now kill a tumor with no surgery. So it's going to still be there, but we want to kill it. And how much dose we give, we need to know the intent of treatment, the proximity of the organs, what the organs are nearby, and how things move. And I'm not going to get to cover all this. I can in questions if you want. But the idea being that we have this, I'm sorry, covered by my there. We have this idea here where we have organs at risk or things that we want to avoid. These are like a bronchus, a bone, the skin, the muscle, and then a target. These are ways that we want to try to kill the tumor. And what can happen sometimes is they butt up against each other. And what SPRT does really well is it helps us negotiate how to best deliver the tumor or dose to kill the tumor, but spare the organs at risk as best we can. And so the way we do that is by delivering what's called SBRT in this framework. We've learned what doses to give. We know if we give more dose, more biologically equivalent dose, it increases the chance of killing the tumor. But if we give too much dose in certain parts of the body, it gives too high of a risk of toxicity. And I wanted to show this because this is a lung patient that I was talking about, a patient with sarcoma that spread to the lung. We know that with SBRT, this is called the no-fly zone. Here's your airways, and I put a heart there to orient everyone. We're kind of looking at you straight on, 2 lungs on either side, and then here's your heart. And the idea being this dotted line is if you're really close to the center of the chest, trachea, the big bronchi, or the heart, if you give too much dose too fast, you can really hurt people. So we call that the no-fly zone. That just means you got to slow down a little bit and give a few more treatments of SBRT, and then it's perfectly safe. And so this came from all the patients that participated in trials and all the investigators that learned this for us, where now we can deliver SBRT very safely to radiate to lung metastases from sarcoma in many patients. And there's lots of ways to do this. In my patient, it was a single fraction that we decided, so a single treatment because it was kind of far away, but there's many reasonable choices. And I wanted to just show you this. This is the important part. So I build this plan for the patient. She gets on the table, and then here's your lung tumor. Here's my target. And what I'm showing you here is literally underneath in these 2 checkerboard parts, we have the planning scan. In these 2 checkerboard parts, we have today's scan on the table, and I can show you how I can compare them head to head, and they look exactly the same. And my physicists have done lots of work to tell me that if I do this, then I know that my dose is going where I want it, and therefore I can kill the tumor. And my point being here is that you need that image guidance, right? We can give huge doses of radiation. We just got to know where we're going and making sure that it's in a small enough area. And in fact, this is high risk to the point where we do so much of this. I'm actually at the machine for this. My physicist is at the machine, and we sign everything off to make sure that it's what we want before we deliver it. Give me 2 more minutes to deliver this last case really quick, and then I'll make sure there's time for questions. I wanted to give you one more example of how SBRT can help, but now we're not trying to cure a single lung tumor. We now have a metastatic patient that has pain. We want to help that. And actually, I wanted to tell you more broadly that we don't even need to do SBRT. We can do any kind of radiation, including external beam, protons, brachytherapy, anything can help here, but we can give what's called palliative radiation therapy, where it's a new framework in my head. It is a short course. We're picking a lower dose, a good technique, intentionally to make people feel better and minimize the time on treatment. So this is like, you have like, unfortunately, a bunch of lung mets, maybe, or a spine met, one of them's causing pain, and we want to help somebody quickly get in and get out and let them get on with their life. And we select how we do this based on many things. And so I encourage trainee radiation oncologists just to think as broadly as you can. This is the part where we get to help people in so many different ways by being creative. And this is where I like to talk about the magic healing rays. There's no cutting. And here are things that I have personally done all in patients with sarcoma in the last couple of years. I've improved pain for people, improved breathing, give them time off chemotherapy. We've given improvements in swallowing if it's messing with their esophagus. We can stop a bleeding tumor. We can prevent fractures in a bone. All these things can be done with it's not magic, it's biology, but it feels like magic sometimes. And we can actually do this sometimes in as little as a single treatment, right? So it's very convenient for people. And so let me give you my case of a young patient. Guy's got retroperitoneal sarcoma again. He actually has been cured of that, but now it comes back in the spine, unfortunately, 3 years later, comes back in the spine. They got some back pain, and all there is this little L2 lumbar spine metastasis. And there's no issues there with the cord or anything like that. The oncologist of the patient calls me up and says, hey, can you help with pain? And so what we can do here is lots of things. We can do anything from a single treatment that's simple and easy for the patient. We may not even have to do a planning scan these days. We can make it as comfortable as possible. One treatment, low cost, easy, low side effects, but you don't get as much bang for your buck there. And so if someone is like end of life and you want to help them with as little burden as possible, this is a great choice. Simple, single fraction, old style radiation therapy. Now, if you have someone who's very fit, they have a single spot, and you want to give them really strong, durable radiation that's going to last 10 years, and you might want to hit it with a little more dose, this is where SBRT might help you, or we don't do other forms of dose escalated radiation. But the trade-off is the patient needs to come for an extra visit. For a CT SIM, they might need an extra MRI. They're going to be rigidly immobilized on the table, which can be uncomfortable temporarily. It's going to be more than one visit, and it's expensive, usually in the US, not for the patient, but for the system. So it's things that we need to think about. And so in this patient who's very fit and is in a lot of pain and otherwise very active, and this is the one reason they're not out living the life they love, I want to hit that hard and fast and make it last a long time. So that I pick SBRT for. And the patient also told me, look, I can only come for like 1 day. And so I'm going to pick SBRT to give a lot of dose. I wanted to drive this home with my last case slide and just show you. This is a patient where the metastasis in the spine is right here. I've gotten the MRI because I need to see these nerves in the spinal cord. And I'm sorry I'm going quickly, but I can explain this if you have questions. And what I need to do is make sure I deliver a high dose of tumor, but I got my nerves right here where I can't deliver a high dose. Here's that figure. Remember those organs at risk and the targets are butted up against each other? SBRT is great for this. And so what I do is I give a super high dose for the spinal bone. And then I ask my physics and therapy team to make sure that we make that dose go from 30 gray all the way down to less than 15 by the time it hits those nerves. That's what they can take safely. And then we use our imaging to make sure that we're spot on there. And so this treatment went really well for this patient. I was able to deliver it in 2 treatments and not 1, and they've had great pain relief in the long term. And so I'm sorry to rush through the end there, but I want to leave time for questions. Let me just conclude by saying, radiation therapy is a vital part of your care if you have leiomyosarcoma. You deserve to meet with a radiation oncologist if you haven't heard of them, and they would always be happy to meet with you. The care they provide is to give radiation therapy as a treatment. That's primarily what we do. We're not the only ones that do it. I think we're the best ones, but we are probably the most common ones. Radiotherapy is both for cure and for comfort. It does both. And so even if there's metastatic disease or you've been told that we're not curing it, there can still be help that radiation therapy can give you. And then the best part about this job is the evolving technology, and we can do so many things these days. And it's not like a better knife. Like we talk about a better knife like we're a surgeon, but we've actually changed the biology where SBRT is doing things for patients that radiation could not do 20 years ago. And like preserving time off therapy, ablating metastases, things like that. And so have an open mind, ask your friendly radiation oncologist, and always feel free to reach out if you have questions. Here is my stuff. You mentioned the Accelerators podcast. That's the one where the doctors argue about doctor stuff. You are more than welcome to listen, but a lot of it's policy related, not all that interesting to patients. Oncology Unscripted is the one where I have joined up with a patient that has sarcoma, actually, and another patient, both of them amazing patient advocates. And we are trying to do a podcast like this where we bring patients into all the interesting, sophisticated stuff that we talk about, not dumbing it down, not removing the controversy. So that's our goal there. And feel free to give it a listen. We did like 4 hours on radiation. So if you want to like nerd out with me on that, I have plenty of content for you there. That's
Wow.
yeah. Sorry, I was
That was fascinating. Thank you so much. I hope we have a lot of questions. Let me look in the chat box here. Oh, I'm sorry. Did I cut you off?
No. I want to leave time for questions, and I definitely skipped over some stuff, and so we can go back to that if people want to. I think I was overly optimistic in how much I can get through in a half hour.
It goes fast. It goes
Yeah.
fast. So I have a question while I'm looking for the chat. Between surgery and SBRT, is there one indicated more than the other, or is there a reason to do one versus the other?
I love that question. That is the question to ask. I don't have a good answer for you. I'll just be blunt and tell you what's challenging is that we all want to do the treatment that we love. And so surgeons think surgery is the best. Radiation oncologists thinks radiation is the best. Couple rules. If patients are very young, right? So 20s, 30s, and 40s, because it's sarcoma, that's a real population we see. There are long-term side effects of radiation that are rare, but are concerning. For example, can radiation form a cancer in you? Can the treatment form a cancer? The answer is yes, but I'm going to give you a caveat that it is incredibly sophisticated, complicated, and not that well understood. Patients on this call, please do not worry about getting a cancer from your radiation. But if you're 20 years old and you're talking about SBRT versus surgery, surgery offers no long-term risk of malignancy. And so we often pick it for that reason. Another common thing is, let's say that there's 12 metastases in the lungs. A good lung surgeon can go in and get all those in a single day. I can't deliver 12 SBRT courses in a single day. And so a lot of times you want this multidisciplinary discussion to like work out these logistical questions to like kind of get the best treatment. The best case scenario is you got both the surgeon and the radiation doctor figuring it out together.
Great. Okay, I found the chat box. So Catherine wants to know, would radiologists do I can't even say it, hysterotripsy
Yeah.
if
Yeah.
if it was available instead of radiology?
Yeah. So histotripsy for the audience is a new technology. Whoever asked, I believe you're asking about this histosonics thing, which I assume is it's a focused ultrasound technology. So it's a separate thing, and it is a brand new technology that's actually pre-prime time, I guess is a good way to put it. So if you go to like your center at home, they may not have it at all. We don't have it at my center. The reason I haven't answered your question is it could be a radiologist, a surgeon, an interventional radiologist, or a radiation oncologist. Those all make sense to me. I don't know who it's going to be at my center, and it could vary across centers. Great question. That's the one the doctors ask. Yeah.
Okay. Sachin wants to know, does SBRT work with multiple lung nodules?
Yeah. So, okay. So there's kind of two pieces to this question. So we design our treatment targets and our fields around what's called an isocenter. Don't worry too much about that, but the idea is that's like a single area we can treat. And so if you can fit the lung nodules into a single isocenter, you can treat them all together in a single treatment. However, if they're all over the different parts of the lung, so say there's one in the right upper lung and one in the left lower lung, those often need to be treated with two separate treatments. And so you can treat them. Sometimes you do them all together in the same day. Sometimes I might do one and then the other the next week. Sometimes we do one and then watch one for a while. So we can do all different things, and it kind of depends on your case and the different aspects of it. And I would tell you, it's not just the anatomy, it's like lots of factors, and it has to do with logistics. So that's a great question. I think the answer is yes, but like the caveat is we have to talk about your individual case.
Yeah, and I think Caroline had the same question. So we'll go on to Maya. Do you need to go to a high volume sarcoma center for SBRT?
Yeah. Um, Okay, so yes, I would say yes. And the reason I say that is that we do know for a fact that the quality of SBRT matters a lot. I'm a quality nerd, so I'll talk about this for hours if you let me. But basically, you can do bad SBRT and it can hurt people because the dose is high enough. And so you want to go somewhere that knows what they're doing and they're doing it a lot. What I would tell you is that every radiation oncologist these days and every medical physicist is trained to do it. So like, it's not like you need special training. It is part of our training, but like any procedure, just like with surgeons, you probably want a surgeon that does a lot of them. Now, what's the caveat? What is high volume? Your guess is as good as mine. I don't know. Here we do, I mean, God, we probably do 2 or 3 cases a day. That's definitely high volume. And so I always tell people we do a lot of this. I'm comfortable doing it. Many centers are high volume. They don't have to be a very large academic center like they might be for a high volume surgery, for example. Yeah.
Okay,
Great
great.
question. Yeah.
So Kathy wants to know, we were told by sarcoma specialists that there are too many lungs, radiation would fry the lungs. Are there cases where radiation is just not possible?
Yes. Yeah. Okay. So, yes, I like to tell patients that nothing is 100% or 0% in medicine. And the minute you say that, you're going to get burned because we'll find situations where it's a caveat. The common ones in this case would be if the most common one is if there's lots of prior radiation. There's a limit. Now, to clarify, and we talk a lot about this actually on one of our podcast episodes, there is not a dose limit to your body in general, right? So there is no upper limit of how many courses or how much dose you can get to your body. Now, if you pick a specific part of your body, like your right upper lung, that has a limit. And the limit is related to what structures are there. And so in this case, it would be like the bronchus, the airway, and the esophagus or the blood vessels. Those are things that have limits. And so we can sometimes it's not the best choice. But I always like to emphasize to patients that what you want is you come with your situation to a team and they figure out what the best choice is. Sometimes radiation is the worst choice among lots of bad choices, or sorry, best choice among lots of bad choices. And so you may be told by your doctor that there's significant risk in what we're going to do, but it's still the best choice. And so I don't think it's good for patients to feel like there's a hard limit because the answer is always is never just no, right? It's always it depends, and you have to kind of know. But to Kathy's question here, there are patients that I tell them that I think radiation is not the best choice, and it might be something is better. We don't usually say like fry the lungs because that doesn't really happen. But yes, that
Descriptive.
Yeah.
Let's see. How about liver mets? Can you use SBRT on liver mets?
Yeah. Yeah, and I'd actually tell you that you can SBRT anything if you want, to be honest, because it's just a technique, right? It's not a special type of treatment, and this is our fault. Radiation oncologists do a bad job of defining this because it's not a special machine, it's not anything like that. It's just a technique, right? It's just as if a surgeon did a type of surgery, and so we do frequently use it on liver mets. Spine, liver, lung, and brain. Those are places that we use it very, very commonly, and you may hear about it. Brain mets are very rare in sarcoma, so it doesn't come up very often, but these are things where you'll hear about it a lot. But you can SBRT bones. We SBRT adrenal glands often. I did that today. Those kinds of things. And so liver is a very common one. And if you wanted to like nerd out about liver, I can actually point you to a 2-hour podcast on the accelerators all about liver SBRT and how we do it and why and all those kinds of things. Yeah.
Oh boy. Is this the same thing, SBRT, same thing as CyberKnife?
Oh, yes. That's a great question. So SBRT, stereotactic body radiation therapy, SABR, SABR, stereotactic ablative body radiation therapy, and then SRS, stereotactic radiosurgery, are all in the same realm. They are actually billing terms, to be honest with you. That's why we use them in medicine, because it defines our billing strategy. But they're in the same realm of high dose, low number of treatments. Now, CyberKnife is a product, so that is a type of machine that delivers SBRT. And that's actually where they cut their teeth. So CyberKnife is a product that has been around a long time. That was one of the earliest ways to deliver good SBRT. And so it's very popular for that. But like, for example, my machine is called the Varian Edge. And if you ask people to compare them, that is incredibly controversial. We've never been able to show it's that different. And you can imagine that whoever uses their own machine thinks it's the best one. And that's just the way it often is. And so
Right.
hopefully that answers. Cyberknife is a product, but it is a machine that is known for doing SBRT. So that's why the term often comes up.
Okay. Tish, my cancer nodule is on the left, close to the aortic arch.
Yeah.
So we can't do surgery on that one. We'll do surgery on another nodule before SBRT. Any idea how many SBRT sessions do you think I'll have to do?
Yeah.
So
I
you're gonna do SBRT. Tish, you may want to unmute. You want to do SBRT after you do the surgery.
Yeah. So
Yes.
So
That's what they have recommended.
yeah. So I want to
Let's do both.
So, right.
Yeah.
So here's what I'd like to do, and I will answer your question too, Caroline's the other really good one. So I want to be very clear that I'm not commenting on a specific case, right?
Yes.
And the reason why is that it is so hard. Like, you need so much detail to answer this well. And the answer that you get from me is going to probably be different than a different radiation oncologist, because there's a lot of controversy around this. What I would say is that there's a couple concepts here. So one is it is very common for us to decide as a team that most of the nodules can be taken out with surgery, but oh, we have this one that's in this one spot that if I go there, it's going to be really risky, and I just would prefer not to go operate on that. And so instead we treat it with SBRT. That's very common. Can you clarify, is that what you're saying? That like,
Yes.
Okay. So it is not uncommon for one to get treated with surgery and one to get treated with radiation. And that seems crazy. And it might be okay to ask, like, why aren't we just doing it all with one? And your doctor should be able to tell you that. But I've done that many times before, because it comes up where some lung tumors are easy to take out with surgery and some aren't. Sometimes it's easy. Sometimes you really want to get it out so you can get pathology. And even if you're not going to get them all out, you want to get one out. There's lots of reasons to do a mix of treatments. And the reason they're probably saying this is that next to the aortic arch, it's not in my very accurate anatomy. Am I still sharing? I am, right? Can you guys see the slides still? Okay.
Yeah.
So my very grossly simplified chest here, the aortic arch is kind of like right here. And so it's in an area that's difficult to work on as a surgeon. And then it's also in an area that's somewhat controversial in how best to treat it. Let me reassure you and tell you that SBRT next to the aortic arch is very safe in a first course. I've done that a lot. Radiation oncologists do that all the time. Totally safe to do. Definitely eligible for SBRT, not always in this no-fly zone. How many treatments? My standard usually is 5. That's a very common choice, 5 treatments. 3 would not be wrong. 15 would not be wrong. This is a thing where when I used to train residents, if we get a case like this on our board exams, we would talk about how you can't really give a wrong answer, but you better understand what you're talking about. And so the conversation that if I was in your shoes, I'd have with my radiation oncologist would be, how worried are they about a toxicity due to the proximity, how close the sensitive things are? And if they're not that worried, you can do less treatments. And if they're pretty worried, you can do more, but realize it's a trade-off, right? It's never like less is always better, more is always better. It's kind of patient by patient. Hopefully that answers your question as best I can.
Thank you. Yeah.
Yeah, thank you. Yeah, and just a reminder, Dr. Spraker can't comment on individual cases for obvious reasons. Thoughts on proton therapy? Why don't you explain what proton therapy is to us?
So I should have put this in there. I'm sorry I didn't. So the proton therapy is pretty straightforward. Basically, the difference that you need to understand is that it is the same concept. We are using a machine to deliver a beam of radiation. What is different about proton therapy is that the beam is different. It is a different substance. It is a particle and not an X-ray. I don't want to give you guys flashbacks of your high school physics classes, but basically, because it's a particle, we can stop it. Okay. So basically, when you give an X-ray, you shoot this beam and it goes through and through. And you know that. That's how we get our images, right? The only reason we can take an X-ray picture is because the beam goes through and out to the other side and we can see it. And that's how we get our pictures. And the radiation therapy that we do what this is it's basically taking these beams that go through and through, and it's adding them up in an intelligent way so that you keep the high doses in the place that you want it. That's what IMRT is. Now, proton therapy, it doesn't go through and through. You can put it into someone's body and you can stop it. And so the idea being that you can use less beams, and then what you can do is you can actually deliver less of the low dose radiation. Now, here's where it gets controversial. The low dose radiation, we don't actually know how much that matters. And I don't mean to be blunt with it and tell you it doesn't matter to you. But if you ask me, if you give me 20 gray of radiation, what's that going to do to my arm or my breast or my lung? I actually don't know. And in most patients, it's nothing. In a lot of patients, it doesn't do anything that we can detect, or we don't understand it well enough to be able to show that. And so in those low doses, we don't know if it's that different. And so therefore, we don't know if proton gives an advantage over photon therapy, or X-ray therapy is the other word I can use for photons. Now, where the low dose may matter a lot is in young children. That effect of a second cancer from a radiation therapy course is more likely in young people. And we think it might be related to the low doses that are delivered. And if you can minimize them, maybe it helps with that. Now, what gets really challenging is that the high dose has to be the same. If we're trying to make someone feel better or cure their tumor or ablate their lung metastasis, that high dose is needed. You can't go down on it. It has to be there. And so the high doses of what you're treating is going to be the same for photons and protons. And so that's where it gets really controversial. And I would tell you, I'm not super excited about proton therapy for sarcomas as a blanket statement, because I don't know that they solve a big problem in the sarcoma world, and some things are a little bit worse. For example, a lot of X-ray or photon machines have better imaging than a lot of proton machines today. That will probably change in the next 5 years. But remember how important imaging is to making sure you deliver your dose to the right place. And so when imaging is like my top priority, I actually prefer photons. And so I hope I didn't confuse everyone. What I'd actually encourage you to do is we made a whole video. My co-host, Julie, who has a sarcoma, she's a young patient. It's of the chest wall. And actually, it's a case where I decided to use proton therapy. We made a whole YouTube video, like for an hour, all about why we chose it, the doses, like why it's different. We go through her plan. We tried to do a good job with this. Of course, I always think it could be better, but I encourage you to go watch it. It's our only video on our YouTube right now, but it is exactly that question. Why did we pick protons? Why may not you pick protons? We're trying to help people understand that a little better.
Wow, thank you. We've got time for 2 more questions. So when you radiate the lung, are you certain that the nodule or the mass is tumorous?
Yeah, you are if you have a biopsy. This is a whole can of worms. Your doctor could treat your tumor. I'll give you the best general way of putting this. If we know from the scan or the image that your tumor is nearly 100% certain to be a cancer, a biopsy, all that does is introduce risk. It doesn't help you learn anything. And so sometimes we do treat without a biopsy, but it better be, we better know why. And normally we do get a biopsy, but it's possible and we're not always certain. And so to Martin's question, I have a much longer-winded answer to that I give in consults, but that's the best I could describe it quickly.
Okay, and then last question, my favorite, Macy. What are you most excited about going forward in the future? And specifically, what research do you think we still need to do in the area of LMS?
Yes, yeah. So what I would love is I'm sure you heard from Dr. Ganju how much the medical oncologists are running ahead with understanding the biology of sarcoma. I mean, they are teasing apart what I still call just sarcoma to the very specific type of leiomyosarcoma gene mutation, whatever, right? I want us to get there too, right? I'd like to be more like the medical oncologists and less like the surgeons, where I'm just treating tumors based on anatomy and what they look like. I'd like to know what it is. And we have some hints in the radiation oncology world outside of sarcoma, but in other diseases, where the genes may tell us how much dose something needs. So it could be in the future that certain types of sarcoma get less dose or more dose, and we give less toxicity or more cures. And that's really what I'm hoping to see. So for me, it's biology. We gotta get caught up to our medical oncology colleagues to understand the biology much better.
Okay, and how would someone get a consult with you?
Yeah, if you don't know, oh, with me,
Yes.
shoot me an email. My email's on
Now
here.
have a fan club.
Yeah, no, you're more than welcome to. I'm in Denver, Colorado. I would be more than happy to talk to anyone. And there's a small group of sarcoma people that do stuff in Denver, and they're great. And so if you're here in Colorado, I'd love to help you out. You can always just email me. And if I'm not the right person, I'll help connect you with them. Yeah.
Okay. Well, we can't thank you enough. This was a lot of information. The case presentations were very visual and very exciting to listen to. So thank you very much for your time and your effort and your help.
No, absolutely. Thank you for having me. And just for everyone that's still listening, if you see my slides or the talk and I skipped over something, like, please just reach out. I'd love to talk more about it. I just, ran out of time. So just reach out anytime whenever you need to, and wish you all the best. And thank you again for having me.
All right. Well, thank you.
Yeah.
We really appreciate it.
Thanks a lot. Have a good rest of your night, everyone.
All right. Bye-bye.